All right, we are going to get started. Do we have his slides? Oh. Well, while we're pulling up the slides, please continue to eat. This is, eat and listen. I'm really thrilled to introduce our keynote speaker. I was really excited about nominating him, and so I get to have the pleasure of introducing him. So Dr. Andy Harris is a pediatric transplant and cell therapy specialist at Memorial Sloan Kettering Cancer Center in New York. He did his med school at Case Western. He's actually from Ohio, for all the Ohioans, from Toledo, Ohio. Did his med school at Case Western, and then residency at Cleveland Clinic, and then fellowship at Michigan, and was there for a few years, then went to University of Utah, and then now is at MSK. And again, he's a pediatric transplanter. He's an internationally recognized expert in graft versus host disease, is the director of the MSK Kids Multidisciplinary GVHD Clinic, where he leads a team that sees children from around the region to help manage their complicated and treatment refractory GVHD. And I think that's really cool because I don't know of any, other pediatric focused GVHD clinics. So I think that's amazing. He leads international trials working on new testing and treatment strategies for GVHD. Another amazing thing about Dr. Harris is that he's a 27-year leukemia, stem cell transplant, and GVHD survivor, which was his motivation to get into this challenging field of medicine. And so again, we're really excited. I've known Andy now for many years, and he's just an inspiration, on many levels, and we are really excited to have him as a speaker, since he's able to speak about GVHD from the personal point of view and from, as one of the experts from a professional point of view. So, Dr. Harris, take it away.
Thanks for the really kind introduction, Amy. We've known each other for, 12 years, give or take now. It's a real honor to be here speaking to you all today and being back in Ohio, getting back to my roots. I've known Meredith for a few years now, and the work that she's doing for her foundation is really, really special and really incredible. So it's really a joy and an honor to be here. I'm going to talk a little bit about my journey to getting where I am today, and then talk a bit about my clinic here. There are a handful of multidisciplinary GVHD clinics around the country. As Annie appropriately mentioned, there's fewer in pediatrics than there are in adults, but there are a lot of them out there, and all of them are a little bit different in how they do things. So I'm going to share a bit about my philosophy and vision for how we do and why we do what we do there. And certainly there will be time for some conversation afterwards. So I'm going to start here. This is my freshman year of college spring break. We are in Florida in front of Margaritaville. This is my older brother to the left of me, and I'm the one with the long hair here. I was in engineering school. I was playing semi-professional soccer and having a relatively fun life. But I wasn't really enjoying engineering and switched to a pre-med major for my following school year and started in the lab. And unfortunately, while I was actively playing soccer, in fact, I was getting encouraged to try out for the Columbus Crew because they were still having open tryouts back in the late 90s with how early the MLS was. I went from, over my winter break for the holidays, going from being a world-class fitness, being able to run miles upon miles without issue, to having to stop to catch my breath on campus while carrying my backpack, which was certainly not expected. And unfortunately with that, we made a diagnosis of acute myeloid leukemia in February. It was Friday the 13th of February, 98, and I'll never forget that day. I was transferred up from Toledo to the University of Michigan because it's the closest large academic center. And this was me the night before I shaved my head. My girlfriend, who is in the back upper right there, always wondered what I would look like with dark brown hair to match my eyebrows since I always had that blonde hair. And so we did that night, and then the next day we shaved my head. And then I went through my first 2 cycles of chemotherapy. There was absolutely no response to that chemotherapy. It was, for the doctors in the room, escalating dose eye to doctor. And this study in the Children's Oncology Group at the time was the CCG. The COG wasn't even founded yet. Was stopped because of toxicity. We were having too many patients die due to toxicity of the therapy, even though it seemed to be very effective. For me, I got through the therapy, but my leukemia was still, I think, roughly 60% blast after induction, so I was a primary induction failure. We got a relatively new salvage therapy that got me into remission at the time. It was mitoxantrone, etoposide, and cyclophosphamide, for those in the room that know these things. And went on to a transplant for my sister, you see in this picture on the right. And roughly a month after my transplant and discharge, my family had been going to this summer vacation spot every single year that was roughly half an hour from the University of Michigan. So they gave me the permission to go there instead of going straight back to my house. And we had some fun while we were there. Here you see we were in togas. So throughout that summer, I was working on getting back in shape and trying to figure things out, but had very frequent follow-up in the hospital until I started to get very, very jaundiced. And I developed biopsy-proven acute GVHD of the liver that unfortunately did not respond to steroids. And back in 1998, there was not a lot of treatment for graft versus host disease that did not respond to steroids. And so at that point, my parents had told us to get my affairs in order. This is a picture. I had put on a lot of steroid weight, was still quite jaundiced. My brother and sister were brought up to see me to say goodbye. And at that time, I promised that if I made it through, if I survived, I was going to come back and work on making transplants safer and more effective, because what I was going through absolutely sucked at the time. And so I'm sure you can figure out, I made it through. And as my lovely and talented wife, who's in the back of the room over there, could tell you, I was stubborn enough to see that promise through. So over the following 10 years, I finally got back to college, completed my undergraduate studies, and that took 3 years since I was through a year of college. During that time, I started training martial arts, taught martial arts, and had the opportunity to go train soldiers and go around the country and teach women self-defense. Went on to medical school. During medical school, I became a husband and a father, and becoming a father was a big surprise to us because we were told that wasn't going to be a possibility. So there was a lot of interesting conversations with family members about the fact that we were expecting children. Then went on to my pediatric residency, as you heard, at the Cleveland Clinic. And then 10 years and 36 days after my bone marrow transplant, I showed up back at the University of Michigan as a pediatric hematology and oncology fellow, which is a doctor in training. So my very first month as that children's cancer doctor in training, I was on the bone marrow transplant service working with Dr. Yannick, who was my primary transplanter. So the two of us, for those 2 weeks together that we went about seeing the patients and everything else, didn't say a single thing about the fact that I was this patient before. And so at the end of it, I said, Greg, I've been working really hard to come back here and do this. I've got to say it's been an absolute joy getting to work with you, and it's been very surreal. He looked at me and said, Andy, think of how weird this is for me. So it's been it was a wonderful journey, and from there, I started my career, focusing on bone marrow transplanting and graft versus host disease. So as a cancer fellow, part of your job during those 3 years is to do a research project. And my research project identified a blood test that helped us with diagnosing and prognosticating for acute graft versus host disease that affects the intestines. And as a follow-up to that, we worked on revising our staging and grading guidelines for acute graft versus host disease. And I had the privilege of being the first author for a paper that now is what is used internationally for acute graft versus host disease data capture on any clinical trial that's capturing clinical data. So my career got off to this huge jump start from being in the right place at the right time and taking advantage of the opportunities that were given to me. And then we had this mass exodus of our bone marrow transplant team at the University of Michigan. I moved across country to the University of Utah, where I had to reinvent myself a bit. So there, on top of working on acute graft versus host disease, I started to work on chronic graft versus host disease and started collaborating with a good friend, Kirk Schultz, who's up in Vancouver, British Columbia, Canada, on working on biomarkers for graft versus host disease, that's chronic graft versus host disease in children. And we're still doing the analysis of this second iteration and starting to figure out the next phases of that. Unfortunately, Utah was not a great fit for our family, even though it's an absolutely beautiful place to live. And we moved across country 4 years ago to Memorial Sloan Kettering Cancer Center. And when I went there, I was tasked with leading a pediatric multidisciplinary GVHD clinic. That's going to be a big part of the rest of this talk. as well as overseeing our portfolio of clinical trials in both acute and chronic graft versus host disease. And over the past several years, I've been fortunate to go around the world and around the country to be able to talk about graft versus host disease and treatment, progress, research, all of the above. So moving on now to chronic graft versus host disease and how we manage this. As you all know, chronic graft versus host disease can affect almost every single organ in the body and system in the body. We often rely on some of our subspecialist counterparts to help us with diagnosis and management of things. And so when we see a patient, we send them out to another subspecialist. They come back to us. We hear back from them. We send them over to see some other people. They come back to us. We hear back from them. We send them to somebody else to get additional help, and they come back to us. And as you can imagine, as a patient, this is a lot of time spent going to and from doctors. This is a lot of time hearing from different people, different perspectives, sometimes hearing mixed messages from different doctors, and having my transplant physician trying to coordinate this all, put it all together, and help me figure out how to move forward with my treatment. There's a lot of barriers and limitations in this model. And first and foremost is that a lot of our subspecialists, first off, have very busy clinics themselves, so there's often long wait times for them to get in to see them as a new patient. But some of them are not part of the same health system, so they may not be sharing health records. And on top of that, a lot of them have a lot of expertise in chronic graft versus host disease, so we rely on them to tell us what they're seeing and try to have to put it together ourselves, how this fits into our patient's chronic graft versus host disease journey that they're in, and figure out how to go forward. As I mentioned, there's a lot of time spent going to and from clinic. This is days away from work, days away from school for the children and from their parents from work, traveling away from their support structures and their loved ones close to home. And there's some risk with this as well. You can get some repeats of tests, sometimes that are not needed. There can be gaps in communication between the subspecialists. And certainly the rehab doctor and the pulmonologist are probably not talking to each other because they're not aware that they're both seeing the patient. Everybody's going through the bone marrow transplant specialist. Sometimes things will be missed because they're expected to be seen by somebody else, and you can get some conflicting advice, treatment guidance, things like that. So I think that while these colleagues helping us with the management of our patients is really important for trying to do our best we can for our patients with chronic graft versus host disease, I certainly think that we can do a lot better. And this is where this multidisciplinary GVHD clinic approach comes about. So instead of sending the patient out to see all these different doctors and all this communication, all this travel, why don't we bring all the specialists, all the doctors together in one space and have the patient come to us as opposed to us sending them to them. And this leads to no delays in assessments and assistance, no fragmentation of care. We're all in the same room. We're all talking to each other. And we are able to identify subspecialists that are committed to really learning about chronic GVHD in their area of focus that can really provide a lot of expertise for our patients' care. And when we bring them all into the same room, everybody's able to share their observations, their concerns. They can ask a question of one of their colleagues about how does, for example, I've got a kid that's got both scleroderma and lung GVHD, and so my dermatologist, my pulmonologist were able to talk about how the thickening of the skin around the chest was impacting their lung function and their tests, and trying to get a better feel for how we can work together with both those teams to improve care from both aspects there. We also make sure that something that one of our doctors wants to do for our patient isn't working directly in opposition to the goals of care from one of the other doctors, so we can learn to compromise, work together to find common treatments that are going to make sure that everybody's goals are being met, most importantly the patient's. And we're able to make this comprehensive treatment plan that's harmonized amongst all these doctors to really help move forward through this team medicine. And the last part of this that I'm really excited about is when you bring all these subspecialists together that are at the cutting edge of their own fields, they can bring some of the new treatments, some of the new diagnostics to this clinic, and we can talk about, are these things that may be of benefit for our patients? And if so, let's explore making a clinical trial for our patients using this new thing that's from this other field of medicine to see if we can advance our field and improve our patients' care, improve their outcomes. So in our GVHD clinic, we have a huge team. We have our dermatologists, our pulmonologists, our GI doctors, my rehab doctor. I've got an ophthalmologist who's not in our clinic because they need specialized tools, but is a regular referral, and I've known her since kindergarten, ironically. She was already established with the team by the time I got to New York, but we've known each other since we were young children, so we have a very close working relationship. I also am very fortunate to have a pediatric and adolescent gynecologist who works with our team. This is something that's really a rarity, and I wish that there were more gynecologists that were involved in GVHD care and getting expertise there, because the gynecologic issues that our patients can experience can be frequent and they can be severe. We have dentistry that works with our team that are situated just a floor down and come up and see our patients. We have nurses. We certainly have transplant specialists, which I forgot to put on here. We have a nutritionist that comes. We have our pharmacist that's able to review all the medications with our patients, because they're often on many, many medications. We have to worry about interactions, side effects, and they are able to do education with the patients, but also help guiding us when we're putting a new medication on and how that may impact some of our other medications that we're prescribing to our patients. And then because I'm in pediatrics, we also have child life that comes and engages our patients to make this a little bit more of a pleasant experience, because it's a very busy day when you're seeing all these different doctors. So when I'm looking to bring somebody new to this clinic, and this is something that I get a question about from a lot of my colleagues, is how do you get somebody from one of these fields to come to your clinic? And the first thing is that you need to have a lot of passion, and you need to put yourself out there. So the newest member of my team is our gynecologist, and I had reached out to, because I'm at Memorial Sloan Kettering Cancer Center, and we're a pediatric division within a larger adult cancer hospital. Thankfully, right across the street, we have Weill Cornell Medical Center. So I reached out to the head of gynecology there and said, do you have anybody working in the pediatric and adolescent space that'd be willing to work with my team? She said, well, I don't right now, but I've just recruited somebody that's really going to focus on pediatrics, that's just finished a pediatric training, and she needs a niche to work in, so why don't you reach out to her and see if she'd be interested in supporting your clinic? And it just so happens that she has a very big interest in supportive care around gynecology and pediatric oncology in general. So this was something that she was very excited about, and we're working together very closely, and we're very excited to have her. But for me, that was a lesson that when you're reaching out and they say, I've got nobody in this space, you can say, do you have a young doctor that's still trying to find their home, their expertise, their niche? I can help them build up that reputation, which helps with their promotion and their satisfaction with getting this expertise. And that's really, I think, a nice way of getting people involved in this. So really, it's finding one dedicated individual from each of these places. I can dedicate a day of clinic and preparation once a month for right now, and as things build up, we may have to add an additional day on, but if we're having that much success, it's usually an easy ask to have that incremental increase for them. And so for this multidisciplinary GVHD care model, instead of having the patient going all over the place, we all come together to support that patient and to provide this harmonized global care that we do now. And I think this is a much better model from a quality of life standpoint for our patients, but also from a quality of care that they're receiving as well. So this is our team here. I've got everything from, let's see, the laser's not going to help for all of this, but I've got some of our transplant and oncology fellows will come to learn how to do team medicine in this clinic. And so this gal on the far left, I'll go from left to right, is one of our fellows training in transplant that joined us from Saudi Arabia. And then I have my rehab doctor, Dr. Abanis, next to her, and Binny next to her is our pharmacist that works with us. Dr. Hans was another one of our transplant fellows that came to clinic that day and is now in South Carolina. One of my nurse practitioners, Joanne, is right next to her. Amy is right in front of me there, and she's our pediatric gynecologist. I'm that guy in back with the scruffy beard. We've got a couple nurses in front of Alina Markova, who's our dermatologist, who's excellent and does a lot of work in graft versus host disease from the dermatology standpoint. The tall gentleman next to her is Stanley Joe, who's one of our gastroenterologists who sees our patients. And then Andrea Harris is just in front of him, who's one of our pulmonologists. Not pictured here is our dentist, who comes up and works with our team. And I'm missing our child life specialist and our nutritionist, who are also here every single week. So we've got this nice big team, and everybody enjoys each other's company. We look forward to this clinic every month. And we're working on a lot of papers and research together, which I think is really exciting for trying to push this field forward and being able to share what we do outside of the walls of our clinic to try to help everybody else as well. So how does this work when patients come to clinic? So we actually have to do preparation beforehand. So we look at our schedule. We reach out to any of the outside transplant centers that are sending patients our way that are scheduled to come to clinic and get recent records that we can all review from our different perspectives. And then we have this virtual meeting where we talk about who all is going to see a patient. So if it's a new patient, we make sure that everybody sees them for a global assessment, but for patients that have been seeing us for months or sometimes even years, we have the people that are seeing them for active issues planning to see them, but we always make sure that we're not missing any new things that have shown up when we do our initial interval history with the patient when they come to clinic, and can add people back in that otherwise wouldn't see them because they're doing quite well without any real concerns from that standpoint. And so that's how we get prepared for this clinic, typically the week before, and that takes a little bit of time commitment from everybody, but it's a very quick and easy meeting. We catch up with each other a little bit about how our lives are going as well, so we have some fun with it. And then when we're in the clinic day, we have patients fill out a symptom questionnaire just to make sure that we're looking for and they have a chance to volunteer any new concerns that they have, and we can compare this to the previous questionnaires to see if there's any significant changes for them. And then we put patients into 3 or 4 rooms, 3 or 4 patients at a time, and then we have our clinicians go round robin in to see these patients. Typically, I'll send a trainee or my nurse practitioner in to see a new patient first. But for our established patients that we know need to see rehab or know need to see the pulmonologist, they'll go and see these other patients. They're not waiting for somebody to come see them. And as people go into rooms and come back out, they share with the rest of the group what they've heard from the patient, what they've found on their examinations, their assessment. Are things well controlled right now from my perspective with my area of expertise? Or are there things that need to be done as far as further evaluations, or do we need to make changes in treatment based on my perspective? And so we all go through this round robin, and at the end, we all sit down together and make this global plan for each patient. For the patients that are coming from Memorial Sloan Kettering, I enact those plans. But for patients coming from elsewhere, I really have to engage their local doctor because I want them to still have ownership of their patients, be aware of what they're on, because they're going to be seeing them in the interval before I see them back. And many of these patients I'm seeing anywhere from 1 to 4 months apart to give ample time for GVHD to change, because chronic GVHD, as we all know, is a very slowly progressing disease and with waxes and waning. So if I give them enough time to see how things are really going, that gets rid of that weekly variation, I get a better feel for if we're on the right track or if I need to make changes. The outside referring doctors always reserve the right to say, I'm worried that things are heading in the wrong direction. Please see them sooner. I will always see them sooner if they ask that. So here I have what all the different subspecialists do and how they bring their expertise to bear for our patients. Our pulmonologists look through their pulmonary function testing when they're old enough to perform PFTs and really able to look at things that I'm not able to discern without the formal training that they have as far as patient effort and reproducibility. Looking at, do they think that this is more of a chest wall issue versus an airway issue versus a lung issue, and do we need to get follow-up testing? As dermatologists know, we really value their ability to describe the different skin findings that we have because they're highly variable between patients. There's a lot of very fancy and complex words to describe them that are best left to the dermatologists who know these things very well. Our GI doctors of nutrition not only look at diet and gut health, but also worry about the liver and all other things GI related from the mouth all the way out the other end. Dentists also look in the mouth, not only screening for oral cancers, but looking for ulcers and lesions, can provide topical treatments, special toothpaste, things like that our patients can use. Everybody ends up seeing rehab medicine because of the disability that they get as a result of their chronic GVHD, and they're very good at helping us find ways of helping them optimize their ability to do their daily activities and to get back into their things that they enjoy. I've got a 10-year-old with pretty significant scleroderma that's responded great to therapy that's playing hockey. And so she kept on working with him on things, mobility, because he wanted to be able to fully wind up to take a slap shot. So she was able to personalize some of his physical therapy with his local physical therapist to some of his goals for his activities that were important to him, which I think is great to have that ability to do that. The gynecologist will see our patients in a separate place due to the privacy of that exam, and then circle back to us, let us know if they're providing any topical therapies, if they have special concerns based on their exam, or if they think that from what they're seeing, we need to change our systemic therapy as well. And then the eye doctors take care of all the specialized lenses, the punctal plugging, and all those things. So these all are getting brought to bear on a daily basis in this clinic when we have this. So again, we have this global discussion afterwards where we determine, are we on good therapy that we need to keep going? Have things been stable and under good control for long enough that we are talking about, is it time to start backing off on our therapy to see if things are going to stay under control with less therapy? Or do we need to bring some new medications on board? And how long should we wait before we see this patient back? And we want to make sure that everybody has a voice in that, because it's very important that everybody has their concerns and addressed as well, all advocating for the patient as well as the patient as well. I kind of see the patients at the end and communicate all this, do my own assessments, and then our pharmacist will review medications with the patient when we're making changes. Now, a few years ago, we added in a telemedicine option because not everybody can make it into New York City pretty readily, whether it's because of time, resources, or because of their own mobility and the impact chronic GVHD has on their life. So this really eliminates these barriers for getting this subspecialty multidisciplinary assessment of their chronic graft versus host disease. So how we do this for these patients is instead of having them sitting in the room, we have a computer set up in the room that they log into from home, and we all rotate through that room and see them virtually like they were sitting in that room, and the same workflow applies from that standpoint. So this is great for these patients that are coming from far away. We've had a lot of positive feedback about this and have actually published our experience with this in journals earlier this year. When we're doing telemedicine, it's hard to really assess the skin. There's often poor lighting. So we have patients take photographs of all the different areas of their body so we can get a good feel for what's going on. And we can keep the log of those photographs that we can compare from one visit to the next. So we can look for changes in the skin from time to time. So we have them photograph these areas. We give them these pictures to help guide them. And for my younger patients, they don't look the same, so we have to talk about how to take these pictures in our patients as well. So we have both adult-sized and shaped people and toddler and baby-shaped people that we give this guidance for. And we make sure that we get a good look in the mouth as well, because we have a lot of concerns around the mouth for our patients, not only ulcers, but also the concern for oral cancer that can happen in our patients. We also look at mobility, so we have them take pictures and we'll have them reproduce this for us as well, because mobility is a big part of our assessments and a big thing that can hinder quality of life and the ability to do activities for our patients. And so we go through and do that whole telehealth visit the same way as if they were right there in front of us. After clinic, we do a full debrief to make sure that nothing was lost in sometimes a little bit of chaos that can happen as we're all going in and out of rooms, to make sure that we've got everything properly documented, we're all on the same page, and the recommendations are very complete. We make sure we schedule that follow-up for the next time they come. And then for those patients that come from outside, I set up a virtual meeting with the referring doctor where we have a chance to talk about the patient, what our findings are, what my recommendations are. Let's hold the course where we are right now. Or, I'm worried that we've lost control of our graft versus host disease, or that this is still progressive despite the last time I saw this patient. And these are our treatment options that we have. Based on what I'm seeing with the patient, I'm going to recommend this out of the treatment options. And they can certainly fill in some of the things that patients don't always come forward with, like, well, actually we found out that they haven't been taking their medicine for the past 2 months, and that might be why we're seeing this progression. And I'm confident they didn't tell you. We only found out because we checked with the pharmacist and then filled a prescription and God knows how long. So these things can be filled in when I'm talking to the doctor. That helps me figure out and get a better understanding of why the patient's GVHD has changed the way that it has. It's also an opportunity for me to educate them about some of the newer treatments and how we do monitoring around those treatments, how to give those treatments safely, and then some of the anticipated side effects that they can be watching for with the patients. So I can educate them and empower them to continue to provide good care locally in between these visits to our clinic, which is also nice because it builds up a community amongst our transplant physicians around providing care for these patients. And it gets them comfortable with using me as a resource when they have concerns or questions, the fact that we're having these regular conversations as well. So the vision for this clinic was really to be a consultative clinic for the region and beyond. So I've seen patients from Rochester, I've seen patients from out of state in Pennsylvania. Again, I've established this relationship with the doctors where they'll reach out to me if they've got a patient they're concerned about. I give them instant consultation on the phone for the short term, but if they want them to be seen in this clinic, then I get them with my team to get them scheduled. It also gives access to all these other doctors, to subspecialists that have an interest in chronic GVHD that they may not have close to home, and therefore being able to provide the services for these patients as well. And a big part of this for me is making sure that they still have clear ownership of their patients, that they understand everything that is happening with their patients, because they're the ones that are seeing them day in and day out, so they need to be aware of what's going on. This is not me taking over all of their care. This is me helping them provide care for their patients. And with this improved relationship that happens with these conversations, again, this leads to good education for them and then their local care getting better. There's still a lot of gaps, though, in GVHD care for our patients, and I think one of the biggest ones is early detection of chronic graft versus host disease. These patients typically don't get sent to my clinic until they've already identified that there's a problem, and the problem's not responding to their usual bag of tricks that they have for treating it. And one of the big problems is that the fibrosis or scarring that we see as chronic GVHD can be very difficult to reverse, if it's going to reverse at all, and it often takes a very long time. And when patients first present with chronic graft versus host disease, if you're not looking very close, you may miss some of these early subtle signs that can lead to early treatment to prevent this progression to where we now have restrictions in movement and activities and significant impairment on quality of life. We also do not yet have really good testing that's going to predict who's going to get chronic graft versus host disease, or to help us with diagnosing chronic graft versus host disease when the findings are subtle, or that they may be related to infection versus chronic GVHD or something else that can help us point us in the direction to make sure that we're giving good treatment for them instead of giving time for this to really present and clarify what it is that we're seeing in front of us. And again, the lack of access to specialists for a lot of people is a challenge. Now, one of the things that I see as being a real big challenge for me is I'm in a tri-state area, and a lot of children are on state-supported insurance. A lot of them have Medicaid to help support their cancer therapy, and when you're on a state insurance, there's a lot of restrictions going across state lines. And so I can't do telehealth for these patients when they're at home because I don't have a license in their state to practice medicine, and then their insurance doesn't allow them to come to me because they want to keep their care inside the state. So this is really an artificial border that's more political than anything. So I think that this is a great place for some advocacy saying for some of these rare and orphan diseases like chronic graft versus host disease that we need to tear down these artificial barriers and allow patients to have access to specialty care that's not available close to home for them. So this is something that I think that we can all as a community be vocal about in trying to help get better access for patients to good chronic graft versus host disease care. We also, and when I was in Utah, we had patients come down from Idaho. There was not a single pediatric bone marrow transplant program in the state, so we had all the patients come down to us. For them to have to come down any more frequently than they already had to for additional care is challenging. So because a lot of these kids were on Medicaid, I could not again do telehealth for them. They'd have to come down. So again, if we can address this, I think this would help patients in a lot of different areas, including those that are living in remote areas as well. Another big problem in pediatrics is that when new drugs, new treatments are being identified and tried in clinical trials, we're not being inclusive of our young children. This is something that the FDA said that they want to address, but they've said it, but they've not followed through with action and really saying we really need to have inclusion of young children after a safety run-in for these agents in adult patients. They allow us to take 12 to 18-year-olds, but those 3 and 4-year-olds aren't allowed to go on that study yet, and they think they're being protective. What they're really doing is inhibiting our ability to learn how to properly give these drugs to these children. And we ultimately end up using a lot of these drugs off-label, not knowing how to really, truly, properly give these drugs to these kids because we don't have any other agents that we know are effective in this area. In pediatrics, the only drug approved to treat graft versus host disease is ibrutinib, which is one that almost nobody uses on a regular basis, so we're using a lot of things off-label. The pediatric studies for ruxolitinib have been finishing up and the results are getting reported, so it's helping us with knowing how to dose that. But the studies for belumosudil, which is Rezurock, and for exatilimab are still in the planning phases and getting ready to just start enrollment now. So we're way behind the ball in getting access to the agents for these young patients. And these are patients that we want to have long, full, productive lives, and we're talking 60, 70, 80 years of life that we are really restricting our ability to effectively treat them. We may be setting them behind the ball by giving these impairments in their growth and their development and in socialization as well because of the stigma that comes for some of these children that have an inability to interact with their classmates in a normal way. Another big challenge that we have in our young children is that they are not able to perform the pulmonary function testing that we use to diagnose chronic GVHD that involves the lungs. There's a lot of efforts going into looking at different testing modalities for this, but when it comes to clinical trials, those things aren't ready for utilization in clinical trials, so we have to wait for them to become symptomatic from a lung standpoint. And we know that by the time that patients have symptoms in their lungs, their lung GVHD is already fairly advanced, so that's waiting too long. So we have to come up with better ways to screen these young children so that we can catch them before they have symptoms so we can start treatment early for them as well. So how do we close these gaps? Again, education, outreach, support, remote support and consultation, putting out white articles and opinion articles and reviews that can be used by in the different subspecialty fields. How do we teach other dermatologists to take care of chronic GVHD if they're not close to a transplant program? We can give them treatment. We can give them education through medical journals and papers. Same with all the other subspecialists. What about the local oncologist that sends a patient 150 miles away to the closest transplant center, and then the patient comes back to them? How do we empower them to look for chronic GVHD detected early? Education and outreach, I think, are really key to help with that for our patients. We can't expect the patient to keep on coming all that distance to us or stay close to us when all their support, their work, their schools are back home. We want them to get back to their lives, but we need to make sure that we catch any bumps along the way that are a result of their transplant early so that we can keep those from being an ongoing problem for them. And again, this lobbying to break down these state border walls for orphan diseases, I think will really improve access for a lot of patients as well. So as I mentioned, we have some lung testing modalities that are being investigated underway. I think we're probably going to hear from those in the next session here on this side. But we have some CT-based imaging. There's an MRI-based imaging. And then there's another pulmonary function maneuver called multiple breath washout testing. They're all being investigated, including in young patients that get over this barrier of being able to get testing and screening in these young patients. Again, the FDA is recommending that we include children and teenagers, but they're not following through and giving us that access. We need to keep on pushing them to follow through on these words. And then we have to acknowledge that clinical trials in children are challenging because we do a lot fewer transplants for children than we do in adults. So this takes very large efforts involving all of the large pediatric transplant centers to get enough patients to be able to do meaningful clinical trials. So this takes a huge effort, and it's a very expensive investment for people when they're doing these studies. But we feel that not only is this, warrant the support, this absolutely is an obligation that we have to learn how to give these agents to these children. So with that, I'd like to thank you guys for your attention. Again, a lot of this is my experience. My position on things are other multidisciplinary GVHD clinics in other areas that are very successful, that do things a little bit differently. And I think that most of us are all talking to each other and sharing with each other what we do to try to improve care for our patients, because really that's what it comes down to, is we want to make